All right, we are going to start blood disorders. In this lesson, we will be talking about and comparing iron deficiency anemia, B12 deficiency anemia, also pernicious anemia, aplastic anemia, sickle cell anemia, and thalassemia. We will differentiate between primary and secondary polycythemia. We'll talk about hemophilia type A and von Willebrand's disease. We'll talk a little bit about um, the disseminated intravascular coagulation, DIC. We'll talk and compare acute leukemia to chronic leukemia and discuss the two types of acute and chronic. We'll compare and contrast Hodgkin's to non-Hodgkin's lymphoma, as well as their pathophysiology, manifestations, diagnosis, and treatment. We'll talk about multiple myeloma, pathophysiology, signs, symptoms, and treatment. And then we'll talk a little bit about lymph and lymphatic circulation. So let's start with some of the anemias first. Let's talk and contrast and compare iron deficiency anemia and vitamin B12 deficiency anemia. So what is anemia, first off? So anemia is causes a reduction in oxygen transport. And why is that? Where is oxygen transported? Well, we know it's transported by red blood cells. But what is exactly within a red blood cell that's important? Well, that's the hemoglobin. And hemoglobin has an iron-containing portion and a non-iron containing portion. So we have heme and globin. Globin is a globular protein, and heme is the portion that carries the iron. There can be a decreased erythrocyte count or red blood cell count. The hematocrit below 41% in males, or hematocrit below 36% in females. Anemia is an oxygen deficit that leads to what? Well, let's think about, why do we need oxygen? The oxygen is needed by the mitochondria of the cell to produce energy. So, if you have an oxygen deficit, then there's less energy production in all the cells. So what is the compensatory mechanism to this? Is tachycardia, right? The heart is going to beat faster and harder to get more blood, to pump more red blood cells to the organs, cells, and tissues of the body to try and drive more oxygen there. So the heart will beat much quicker. That is tachycardia. And your blood pressure will go up, which is peripheral vasoconstriction. It constricts to try and increase the pressure. What are some of the general signs of anemia? Well, fatigue. Remember that the electron transport chain, which is the second part of energy, well, third part of energy production, right? You have glycolysis, which is step 1, Krebs cycle, or aka citric acid cycle, step 2, and then the final step is the ETC, which is the electron transport chain. And the electron transport chain involves iron. It involves coenzyme Q10 as well. But if you're iron deficient, then the electron transport chain does not work as efficiently, and energy production is decreased, so there's fatigue. Due to the vasoconstriction, there's pallor, which means pale or a pale face. Dyspnea, which is difficulty in breathing, and tachycardia. So I would know all of those general signs of anemia: fatigue, pallor, dyspnea, which is difficulty in breathing, and tachycardia. What else can oxygen deficit lead to? Well, it leads to decreased regeneration of the epithelial cells. The digestive tract becomes inflamed and ulcerated, and it can also lead to stomatitis, which is a good um, indicator, and it can be seen visually on a nutritional physical exam. One of the things I look for in anemias and nutritional deficiencies is stomatitis, which is cracking of the lips, inflamed and cracked lips. And that can be in the corners, that can be in the center, but it is pretty obvious. When the epithelium is affected and there's a decreased ability to regenerate epithelium, that can result in dysphagia, which is difficulty in swallowing. And the hair and skin may also show degenerative changes because they're all epithelium. In severe anemia, it could lead to angina or congestive heart failure. Okay, these are some very important features that you should know in terms of the pathophysiology. With iron deficiency anemia, there's insufficient iron, which impairs hemoglobin synthesis. And there is the iron deficiency anemia is considered to be a microcytic hypochromic presentation of the red blood cell. Microcytic, small cells, and hypochromic, less color to them. And that is a result of the low hemoglobin concentration in the cell. In terms of incidence, iron deficiency anemia is the most common anemia worldwide, and there can be a wide range from mild to severe. It occurs in all age groups, but more common in women during childbearing age. It is estimated that 1 in 5 women is affected, and it increases for pregnant women. Okay, the etiology, furthering down the line in etiology, the dietary intake of iron can be below the minimum requirement. It could be chronic blood loss, maybe excessive amount of bleeding, maybe there's an ulcer, maybe there's hemorrhoids, maybe there's cancer. So one of the things they typically look for when they find that someone is fatigued and that there's iron deficiency, they'll look for bleeding in different sources internally, not necessarily externally, but there could be internal ulcers. There could be hemorrhoids, they can bleed, and there could be cancers. There could also be impaired duodenal absorption of iron, so maybe the person is consuming enough iron, but they're just not absorbing it. Remember, it's not you are what you eat, it's you are what you can digest and absorb and assimilate. Severe liver disease, that can affect iron absorption as well. So some of the clinical manifestations we talked about before: pallor of the skin, fatigue, irritability. Another biggie is stomatitis, which we spoke about before, and glossitis. Glossitis is inflammation of the tongue. When the person opens their mouth and sticks out the tongue will be enlarged, be red and glossy. Menstrual irregularities, delayed healing, fast heart rate, again, tachycardia, the heart palpitations that can be felt. Dyspnea, which is difficulty in breathing. And this is a new word. I don't think you've heard of this one yet. Syncope. Syncope is fainting, like unexplained fainting is called syncope. On lab tests, again, you'll see microcytic hypochromic red blood cells, again, smaller and less color. Anisocytosis, this is when the red blood cells vary in size. And then Poikilocytosis is when they vary in their shape. Okay, but the key to this one is going to be the microcytic hypochromic. I would certainly know that. I've seen this on so many different boards in the past, and students always confuse this in relationship to iron deficiency anemia as well as B12 anemia. So make sure you put that in your internal database, okay? So here we're looking at microcytic hypochromic. These are much smaller, and you can see very little color in these. These are white blood cells. These look like neutrophils because there's about 1, 2, 3 heads to the nucleus, 1, 2, 3, 4 heads to the nucleus. This is probably a basophil here. But the others all around are red blood cells, and they're hypochromic microcytic. Everything else around this is plasma, all between. The extracellular matrix is considered plasma. Okay, iron deficiency anemia. So treatment is consume iron-rich foods and iron supplementation. Have to be very careful with iron supplementation. Iron is known to constipate a lot of people. So it's important to be aware that there are many different forms of iron and to try and consume it in non-constipating forms. I'm not going to ask you anything on dosages or anything like that. Parenteral iron for patients with intolerance to oral iron or that have gastrointestinal disease or with continued blood loss that just can't be corrected. Parenteral drug administration by non-oral means of administration, but is generally interpreted as relating to the injecting directly into the body. So you're bypassing the skin and you're bypassing the mucous membranes. That's where parenteral iron comes into play. All right, let's look at B12 deficiency. Also another interesting form of anemia. This one has a few more moving parts than the iron deficiency anemia. And look at this one. Look at the pathophysiology. This one is a macrocytic anemia. Remember, iron deficiency was microcytic hypochromic. This one is macrocytic anemia caused by a B12 deficiency. So B12 is needed for normal red blood cell production and is characterized by very large, immature, nucleated red blood cells. Remember, red blood cells are anucleated. They don't have a nucleus. But if the body is deficient and the bone marrow is pushing out these cells at a much faster rate, they can push out these cells well before they are mature. Okay, so that's one of the things that we look for is not just large blood cells, but are there any that are nucleated? Okay, there can be an issue with absorption, right? So these parietal cells, remember in the stomach there are chief cells, and there are parietal cells, and the parietal cells are secreting intrinsic factor. They produce intrinsic factor, and they also produce hydrochloric acid, or HCl, and that's important to know. So the parietal cells secrete IF, or intrinsic factor, and that is necessary for the intestinal absorption of B12, which takes place at the distal ileum. That's important to know as well, because there are certain diseases of the distal ileum, such as Crohn, right? So Crohn's disease targets the distal ileum, and if there's an issue with that part of the GI tract, then it means that they may be B12 deficient, or they may develop a B12 anemia. So the parietal cells are extremely important in the stomach. They produce hydrochloric acid and intrinsic factor. It's important for B12 to bind to intrinsic factor, but it only does that in an acidic environment. So for people that consume antacids, there will be an issue with B12 absorption. Okay, I'll say that again. Many people that have heartburn or acid reflux, many of them are self-medicating for a long time with antacids because you can buy them over the counter. And if you decrease the acids in the stomach, even if there is intrinsic factor, you need an acidic environment for that B12 to bind to intrinsic factor. That's an important feature. B12 is also stored in the liver, and this is an important concept because it's like a bank, it's a reservoir, right? If you're not working for a while but you saved up money, you can kind of live off the money you saved for a little bit. And the same thing happens with B12. It could be stored in the liver, and it takes about 2 to 3 years for that to become deficient before you run out of those reserves. Okay, B12 and nerve cells. This is a really important concept. Remember, if you remember back to an earlier lecture, I showed you the importance of the B6, B9, and B12 in terms of the methylation pathway. I was showing you the importance of folic acid and how many people have this genetic SNP in the methylene tetrahydrofolate reductase enzyme that converts tetrahydrofolate into methyl tetrahydrofolate, and that is such an important form. And we need methylation in order to myelinate for DNA synthesis, RNA synthesis, to make many of the neurotransmitters. It's in order to close the GI tract, in order to close the lips, the hard palate, the spinous processes. Otherwise, you get that meningomyelocele or spinal bifida occulta. So B12 is really important, and it's needed for the function and the maintenance of neurons. There are significant deficits that can cause symptoms of the peripheral nerves. It can actually create symptoms that look and sound a whole lot like multiple sclerosis, which is a demyelinating disease. So there are people who have also been misdiagnosed with MS, and it was a simple fix for those people, which was B12 supplementation. Okay. In terms of etiology, who's more prone to it? In terms of diet, it's more likely in vegans who do not consume dairy, meat, or fish. It is true. There is an argument that greens and vegetables, that they have B12 consumed on it, living on it, and they do. It is just not as highly absorbable as it is from the B12 that's found in dairy, meat, or fish. There's also the decreased production or absorption of intrinsic factor that we spoke about that can result in B12 deficiency. Now, there's a type of anemia that's referred to as pernicious anemia, which is an autoimmune disease where there are autoantibodies that destroy the parietal cells of the stomach. Right? Those parietal cells produce intrinsic factor, and intrinsic factor has to bind to B12 in order to make it into the distal ileum where the absorption of B12 takes place. Okay. If there's a gastrectomy, B12 deficiency, anyone that has the reduction in the size of the stomach, that will affect B12 absorption, even iron absorption as well. Anytime the stomach is tampered with in its size or shape, then there's going to be issues with the microbiome, with calcium, B12, and iron absorption. Okay, in terms of there are some tapeworms that exist that can also be in competition with the B12 that's in the gut. They're rare, but it's something to consider when all else fails. We already mentioned the decreased ileal absorption of B12. We spoke briefly about surgical resections when there's parts of the stomach that are tampered with, or even parts of the intestines that have to be removed, as seen with Crohn's disease. So here we can see on the top the vitamin B12 is ingested by food. Then we look at number 2, where we see parietal cells in the gastric glands that secrete the intrinsic factor, which allows the vitamin B12 to bind with intrinsic factor in the stomach. Then there are these complexes that are formed. We can transport the B12 into the ileum. And B12 promotes the maturation of red blood cells. And normal red blood cells then circulate throughout the system. Now that's normal physiology, B12 doing its thing. Well, what happens if there's a deficit in B12? So the person is consuming B12 in their diet. Here, this person has an antibody reaction that causes atrophy of the gastric mucosa. So there's something that's creating the breakdown of the lining of the stomach where those parietal cells are, which means no intrinsic factor, which means no absorption of B12 in the ileum, which means that the vitamin B12, any of the vitamin B12, is now going to be excreted. So you have lack of B12 that's going to cause the bone marrow to produce megaloblastic erythrocytes, right? There's a demand for oxygen. So the body is going to push them out, or the bone marrow is going to push them out before they actually get a chance to mature. They're immature. So they'll probably not just be megaloblastic, but they may also be nucleated as well. With the B12 deficiency, there can be an enlarged tongue that's red, sore, and shiny. They call that glossitis. There's digestive discomfort, oftentimes with nausea and diarrhea, and there could be neurological symptoms where the patient experiences pins and needles or the paresthesia and tingling into the limbs. The diagnostic test for this on the microscope, they will see megaloblastic cells, those larger cells, and they'll probably contain nuclei which they shouldn't. Mature cells are anucleated. The bone marrow exam is hyperactive. The vitamin B12 serum level is below normal. There could be the presence of hypochlorhydria or achlorhydria, which will affect the binding of the intrinsic factor to B12. I think before you heard me mention how many patients with esophageal reflux or acid reflux self-medicate with many antacids, which will decrease the amount of hydrochloric acid in the stomach or simply decrease it. So the treatment here is going to be either the intramuscular or subcutaneous injection of B12, parenteral B12 therapy. Here is megaloblastic. These are large red blood cells. This is a white blood cell, right? Whenever you see the multinucleated, this is probably a neutrophil. But these are megaloblastic for sure. Here again, we're seeing megaloblastic, large red blood cells. And here, this is the glossitis, red, inflamed, hypertrophic, shiny tongue. It's very smooth, right? It loses, you don't really see a lot of the villi here or the any of the taste buds in here. Just red and shiny. That's glossitis. Okay, let's look at a few other anemias now. Let's look at aplastic anemia, hemolytic anemia, sickle cell anemia, and thalassemia. We'll probably focus a little bit on the aplastic anemia, a little bit on the sickle cell anemia, and a little bit on hemolytic and thalassemia as well. All right, so aplastic anemia, this is a condition of the bone marrow failure that arises from suppression of or injury to hematopoietic stem cells, white blood cells, and red blood cells. So the bone marrow becomes hypoplastic and it fails to produce mature blood cells. Now, there is a term that's called pancytopenia. Pan, like pandemic, compared to a epidemic. Pancytocellpenia, decreased number of all the formed elements. That is the hallmark of the aplastic anemia. Okay, that's really important, and I want you to know that. Okay, pancytopenia, decreased number of all the formed elements, and that is the hallmark of aplastic anemia. Okay, some of the etiology, we'll see it with some autoimmune diseases like SLE, chemotherapy, radiotherapy. That's a biggie too. People that have excessive amount of radiation exposure often get aplastic anemia. There are some toxins that are known to cause it, benzene, toluene, and insecticides. There are medications that can cause aplastic anemia, post-viral hepatitis, and there are some genetic abnormalities as well. So aplastic anemia, again, the pancytopenia, which is the hallmark of aplastic anemia, we will see pallor, weakness, and dyspnea, but we've seen this with the others, with other types of anemia. So this one is not specific for aplastic, but the pancytopenia certainly is. Leukopenia is another clinical manifestation, and that can lead to infection or fungal infections. Thrombocytopenia, this results in mucosal or skin bleeding, and we refer to this as petechia. We'll show you a picture shortly of petechia. And the treatment is the removal of any of the bone marrow suppressants, because the failure to identify the cause and to treat effectively can be life-threatening. Okay, hemolytic anemia. This is a group of disorders that result from excessive destruction of the red blood cell. There's the word lysis, right? Hemolytic, hemolysis. The etiology of this one, intrinsic factor, red blood cell disorders. Most are hereditary. There are membrane defects to the red blood cell. There can be problems with the red blood cell enzyme systems. There are hemoglobin disorders, and sickle cell anemia and thalassemia as the two main hemoglobin disorders that are genetic. There are extrinsic factors like autoimmune disease and infections. A biggie would be malaria. So let's look at sickle cell anemia. Um, Sickle cell anemia, this leads to the formation of abnormal hemoglobin, um, where the main feature in terms of the pathophysiology, this is classic, it's the glutamic acid is replaced by valine on the beta hemoglobin chain. Okay, I'll say that again. That's the glutamic acid is replaced by valine on the beta hemoglobin chain. So there's alpha hemoglobin and beta hemoglobin. This one involves the beta hemoglobin. With sickle cell anemia, there's altered hemoglobin that crystallizes and it changes the shape of the red blood cell when it's deoxygenated. Again, that's important. You have altered hemoglobin crystallizes and it changes the shape of the red blood cell when deoxygenated. It changes the shape to a sickle shape. It's very pointed, has jagged edges, it's not round and smooth, it's kind of jagged. The cell membrane is damaged and it results in hemolysis. If you remember back to anatomy and physiology, the red blood cell lifespan is about 120 days before it tries to squeeze into the spleen. Now, if you look at the diameter of a red blood cell, which could be 7 to 8 micrometers, and then you look at the diameter of a blood vessel leading into the spleen, it's half of that. So the normal physiology of a 120-day-old red blood cell, the membrane becomes somewhat rigid and stiff, and when you have this larger red blood cell that's trying to squeeze into a much smaller blood vessel, the red blood cell ruptures. And now you have the recycling and removal of some of the contents within that older red blood cell. If it's old and can't be reused, we excrete it, and any of the good stuff we can recycle. So here we're talking about with sickle cell anemia, the lifespan is much shorter. It's approximately 20 days. The sickle-shaped cells, these are much too large to pass through the microcirculation, and that causes obstructions. The obstruction can lead to multiple infarcts, right? And when you have an infarct, it can create to a necrosis of any of the organs, the bones, and even the brain. So if you look up on top, in sickle cell anemia, one amino acid, valine, replaces glutamic acid on the beta chain. That's important. It's classical. If you look on B, that is your normal red blood cell, right? It's a biconcave disc. So around the periphery here, it's much thicker, and in the center, it is concave. This usually appears darker on microscope, and the inside, because it's thinner and the light can pass through that, it's typically a little bit lighter in color. It looks like a donut a little bit, right? And here's the sickle shaped. This becomes dangerous and a major problem. So here on the left, we have the red blood cell containing hemoglobin in the presence of oxygen. And this is a very, very flexible cell. When the oxygen level is low, the red blood cell can sickle and becomes elongated and rigid. As the blood circulates through the body, the oxygen level may decrease, the erythrocyte sickles, and are unable to pass through these small arteries. Remember, the cell membrane is damaged, and the red blood cell also has a shorter lifespan of only 20 days. when these irregularly shaped cells are going through these small arteries, you can create an occlusion crisis, right? So now you have tissue damage and multiple infarctions that can create pain and also loss of function. As these cells are trying to go through the spleen and the liver for recycling, because it's the time span is reduced from 120 days to about 20. Now you have the increased hemolysis of the red blood cells in the spleen. And you get decreased red blood cells, you get this severe anemia. When the blood cells are breaking down at a very fast rate, one of the byproducts are bilirubin. And when you have increased amounts of bilirubin, you get this yellowing of the skin, which is called jaundice. Jaundice. In light skin individuals, you can see yellowing of the skin. If you are of darker skin complexion, all you have to do is look at the white of the eyes, and the white of the eyes will look yellowish, which is jaundice as well. Okay, sickle cell anemia, it can be a genetic condition. The gene for hemoglobin S is recessive, and it's more common in individuals of African ancestry and those from the Middle East. In terms of clinical manifestations, it doesn't appear until the child is about 12 months old. Severity of symptoms is determined by the proportion of the hemoglobin S to normal hemoglobin. Severe anemia causes pallor, weakness, tachycardia, and dyspnea. Again, it sounds like any other anemia, but here you get the hyperbilirubinemia, which results in jaundice, and it can also cause gallstones. And the spleen becomes very enlarged, which is called splenomegaly or splenomegaly. Because of the shape of those sickle cells, you can get these vascular occlusions, which are periodic painful crises of permanent damage due to the organs and tissues not getting enough red blood cells, not getting enough oxygen. You can see ulcers on the legs and the feet. There are areas of necrosis in the bones and the organs, especially the kidney. And when there's decreased oxygenation to the brain, you get these cerebral infarcts. And that can cause seizures and even hemiplegia. Hand-foot syndrome, occlusions of the smaller blood vessels in the hands and the feet that result in pain and swelling. Because the blood vessels get a little bit smaller at the tip of the fingertips and to the toes, it's called hand-foot syndrome. And then there's acute chest syndrome, which is occlusions and infections in the lungs. And this can cause death. There can be the delay of growth and development, congestive heart failure, and frequent infections with sickle cell anemia. So here you do have some normal size red blood cells, but here this one looks like it's crescent shaped, right? This one here, they have these sharp points, right? Some of these jagged edges like this. So this is sickle cell anemia. The blood test, DNA analysis is the biggie. And they do hemoglobin electrophoresis as well. For treatment, hydroxyurea has reduced the frequency of this crisis. The dietary supplement with folic acid or 5-methyl tetrahydrofolate. There's bone marrow transplantation and immunization in children against pneumonia, influenza, and meningitis. Okay, thalassemia. Thalassemia is a genetic abnormality that interferes with the production of the globin chains. There is thalassemia alpha and thalassemia beta. It all depends on where the reduction is. If it's reduction in the alpha chains, then it's thalassemia alpha. And if it's reduction in the beta chains, thalassemia beta. The imbalance in the alpha or beta hemoglobin results in hemolysis, right, the breakdown of the red blood cells. The thalassemia is the most common genetic disorder worldwide. Thalassemia beta, higher incidence in Mediterranean countries. Thalassemia alpha, higher incidence in Indian, Chinese, and Southeast Asia. Thalassemia really means like anemia by the sea. We see this in a lot of Greeks as well. Thalassemia, you have the usual signs of anemia, the usual signs of hemolysis, splenomegaly, hepatomegaly, which is enlargement of the liver, hyperbilirubinemia, delayed growth and development in children. There could be heart failure early due to the compensatory stress on the heart. This one shows up with microcytic, hypochromic red blood cells, just like the iron deficiency anemia had, and there's increased EPO. If you remember back to anatomy and physiology, increased EPO, erythropoietin, this is something that is produced by the kidneys. The kidneys produce erythropoietin in response to decreased oxygen, right, and decreased red blood cells going through the kidneys. The kidneys, all the blood doesn't just go through the liver, but it does go through the kidneys for filtration and cleansing, and it is the perfect organ to regulate the blood pressure, and it does so by the use of renin, but it also has the ability of increasing red blood cell production, and that is called erythropoietin. When people and athletes and bikers especially use this, they call it doping. Okay. The treatment is blood transfusions and the removal of excessive iron. They refer to that as chelation or chelation therapy. This is just a little chart that you can use that does a very nice comparison between iron deficiency anemia, pernicious anemia, aplastic anemia, and sickle cell anemia. So you may want to kind of pause this for a second and just do a little comparison side by side to these, okay? All right, blood clotting disorders. Let's look at hemophilia A, Wilbrand's disease, and disseminated intravascular coagulation. Okay, what are some of the indicators of blood clotting disorders? Well, case history. One of the things I always look for is inflamed gums, and I always ask my patients, do they have any bleeding in the morning when they brush their teeth? Most people get up in the morning, the first thing they do, they use the bathroom, and they brush their teeth. So persistent bleeding from the gums is an indication that there is a clotting disorder. Repeated nosebleeds, that is called epistaxis. Petechia. Petechia, purpura, and ecchymosis are kind of in the same category. What differentiates these are size. So petechia are pinpoint, less than 3 millimeters. They're flat, red spots on the skin or mucous membrane. Petechia. There's a lot of capillary fragility, and you start to see these little reddish flat dots on the skin called petechia. Purpura, these are reddish blue discolorations, 3 to 10 millimeters. We see this a lot with people that take blood thinners. You can see it on the dorsum of the hand and the dorsum of the forearm. And people don't even know they can bang their hand against something, and then within a few hours they have all this discoloration. Ecchymosis is reddish blue discoloration, but this one's usually larger than a centimeter. That's called ecchymosis. Hemarthrosis, you see the word arthrosis, which is joints, and heme is blood. This is bleeding into the joints. The joints become swollen, red, and painful. Hemoptysis, this is when someone coughs up blood. And then there's hematemesis. Hematemesis is when someone vomits, and in their vomit there are these brown particles. They're kind of look like coffee grinds. That's called hematemesis. Okay, these are the petechia. You can see that they're very, very small, just a few millimeters. Now, here you can see the petechia, and then we can compare it to purpura. Right? Petechia is much smaller. Look at the purpura, larger surface area. It's reddish, a little bit brownish, a little bit darker. Other indicators of blood clotting disorders, there could be blood in the stool. It could be black. You can see it visually, or it could be occult, which means only under the microscope. Anemias, feeling faint and anxious, low blood pressure, and rapid pulse. Okay, let's look at hemophilia A, also known as classic hemophilia. This is a deficit or abnormality of clotting factor 8, right? These clotting factor 8, this is made in the liver. It's transmitted as an X-linked recessive trait. It's manifested in men. It's carried by women. Hemophilia B, this is called Christmas disease. It is similar, and it results from a deficit in clotting factor 9. And then hemophilia C is milder form and results from a deficit in clotting factor 11. But the biggie here that I'd like for you to know is the hemophilia A, which is a deficit or abnormality in the clotting factor 8, and that clotting factor is made in the liver. What are some of the clinical manifestations? They vary. Prolonged bleeding after a minor tissue trauma, spontaneous bleeding into the joints, and possible hematuria or blood in the feces. Some of the diagnostic tests, coagulation time. They look to see how long it takes for a person to coagulate, to clot. And they look at serum levels of factor 8, and they just look to see if they're low. If they are, then they give this treatment of desmopressin. Sometimes it's referred to as DDAVP, desmopressin. It raises the level of clotting factors, and this is typically given through IV. Okay, desmopressin given through IV. It raises the clotting factor. All right, let's look at the next one, von Willebrand's disease. This is a deficiency of von Willebrand factor. This is another clotting factor that helps the platelets clump and stick to the wall of the damaged blood vessel. There are 3 major types which have clinical manifestations that are similar to hemophilia. The clinical manifestations, you have skin rashes, frequent nosebleeds, easy bruising, bleeding of the gums, and abnormal menstrual bleeding. The treatment is based on the type and the severity, and again, we use the desmopressin. This is found to increase the von Willebrand factor in addition to clotting factor 7. All right, the disseminated intravascular coagulation. It's typically abbreviated as DIC. This involves both, okay, this one's interesting, it involves both excessive bleeding and excessive clotting. And it's a result of a number of conditions which activate the process. So the clotting can be caused by the release of tissue thromboplastin. The clotting can be caused by injury to the endothelium, causing platelets to aggregate. The causes multiple thrombosis and infarctions, and also consume available clotting factors and platelets, and stimulates the fibrinolytic process. So you got consumption of the clotting factors and fibrinolysis. So if you've got consumption of the clotting factors and you got fibrinolysis, so it's starting to break down the fibrin that's laid down, it's going to result in a hemorrhage. It can result in hypotension. It can result in shock. Okay, so this one has a poor prognosis. I have worked with many physicians and many in ER, and they'll say with disseminated intravascular coagulation, DIC, they sometimes say that the DIC, instead of standing for disseminated intravascular coagulation, they say it stands for death is coming. Okay, so if we look back, it causes multiple thromboses, right, which is multiple clots, and infarctions, right? And it also consumes the available clotting factors and platelets, so now you have thrombocytopenia. And it stimulates the fibrinolytic process, breaking down the clotting material. So here we have a primary condition, septicemia, an obstetric complication, severe burns or trauma, and this can cause the extensive endothelial damage, which will initiate the clotting process, or the release of tissue thromboplastin, which will initiate the clotting process. Now that will result in many thrombi that form throughout the microcirculation. The platelets will collect, and when platelets collect, that can create ischemia and multiple infarcts. When platelets collect, that can cause thrombocytopenia. You can have many thrombi that form, and now that will decrease serum fibrinogen, right? Because we're running out of it now. You're basically using up the clotting factors. So one of the clotting factors is fibrinogen, which is inactive, that needs to be activated into fibrin, and that creates the clotting. So when the platelets collect in one given area, then you reduce them, so you get thrombocytopenia. Now you get initiate the clotting process right from the beginning, right? When you have the release of tissue thromboplastin. So that's for the initiating of the clotting process. So that activates the plasmin. That creates fibrinolysis. And fibrinolysis, now you're breaking down the fibrinous clot, and that leads to excessive bleeding. You decrease fibrinogen. That results in excessive bleeding. Now you have decreased thrombocytes. That creates excessive bleeding and hemorrhage. Whether it's the excessive bleeding portion or the clotting, the ischemia and the infarcts, they will both result in organ failure. Okay, so primary conditions such as septicemia, obstetric complications, burns, and trauma. I would make sure you know those. So here, again, we're talking about the disseminated intravascular coagulation, DIC, the obstetric complications, whether it's toxemia, amniotic fluid emboli, or an abruptio placentae. All of these can create that. Carcinomas, they release chemicals which trigger coagulation. The burns, major burns, they can release antigen antibody complexes, which can initiate clotting. The obstetrical patients, increased bleeding. Cancer patients, increased clotting. Right? So this is what we see with disseminated intravascular coagulation, DIC. Um, there's hemorrhaging, hypotension, shock. We've seen these before. And then petechia and the ecchymosis on the skin and the mucosa. There can also be hematuria, which is blood in the urine. Okay, still the other clinical manifestations, vascular occlusions in the small or the large blood vessels, creating infarcts. There's dyspnea, difficulty in breathing, cyanosis, bluing, seizure if there's decreased blood and oxygen or clotting before it gets into the brain. And if there's decreased brain activity, then decreased responsiveness. The treatment is treat the underlying cause and treat the hemorrhages or the thromboses. Okay, let's look at polycythemia and leukemia. These are the neoplastic blood disorders. So primary polycythemia, or also referred to as polycythemia vera, this is when we have increased production of erythrocytes and other cells in the bone marrow. There's increased production of erythrocytes, but serum erythropoietin, those levels are low, right? You would think that if EPO is high, then we're going to see an increase in red blood cell production. So here, with primary polycythemia, the increased production of the red blood cells are high, but what's supposed to stimulate it, which is erythropoietin that comes from the kidneys, those levels are low. Okay? The secondary polycythemia, erythrocytosis, increase in red blood cells in response to prolonged hypoxia and increased erythropoietin secretion. So this is almost like, this seems like a feedback loop where if you have hypoxia, then, all right, EPO is going to increase and we're going to push out more red blood cells. Seems normal, right? In this case, we will see reticulocytes that may appear in the blood, right? A little bit more of the immature red blood cells pushing out as well. In primary polycythemia, it's a neoplastic disorder, unknown cause, begins between the ages of 40 to 60, whereas the secondary polycythemia is more of a compensatory mechanism that's designed to provide more oxygen and transport. So if there are conditions in which the body is recognizing, hey, we have too little oxygen, we need more, like in chronic lung disease or chronic heart failure or heart disease, or you're in a higher altitude, then your body's going to push out more EPO. Or if there is a erythropoietin secreting tumor, like a renal carcinoma, that can do it as well. So in this type of condition, we'll see cyanosis from the distended blood vessels and poor blood supply. So there's bluing, there'll be liver enlargement, spleen enlargement, pruritus, which is itchiness of the skin. There'll be hypertension. There'll be difficulty in breathing, headaches, visual disturbances, thrombosis and infarcts that affect the extremities, the liver, the kidney, the brain, the heart, and congestive heart failure from increased work that the heart has to do to pump out the blood. In polycythemia, they're just going to do, the diagnostic test or increase cell counts, increased hemoglobin and hematocrit values, hypercellular bone marrow, and hyperuricemia. Treatment is phlebotomy. 1 unit of blood is removed weekly until the hematocrit drops below 45%, and the hematocrit can be maintained by periodic phlebotomy. Drugs or radiation, those are designed to suppress the bone marrow activity. This is polycythemia. Now let's look on the white blood cell side, right? We did the red blood cell now. Now we have leukemia, which is a group of neoplastic disorders involving the white blood cells. This is where one or more of the leukocytes type present as undifferentiated, immature, non-functional cells, right? This is why people with leukemia are prone to getting sick and infection, is that although they may have more red blood cells, they're non-functional, right? So these leukocytes multiply uncontrollably in the bone marrow. You have large numbers that are released into general circulation, and these white blood cells will infiltrate in the lymph nodes, the spleen, the liver, the brain, and other organs. But they're immature and they're non-functional. Very important feature. Now let's look at some of the different types, right? So we have acute lymphocytic leukemia, acute myelogenous leukemia, chronic lymphocytic leukemia, and chronic myelogenous leukemia. Okay, let's go back to acute leukemia. This is ALL and AML. Now, this one has a high proportion of immature, non-functional cells, typically blast cells, in the bone marrow and the peripheral circulation. Here, the onset is usually abrupt. It's not insidious. That's the key. It's usually abrupt. If you look at the chronic leukemia, that one is an insidious onset. So with acute, the onset is usually abrupt. There's marked signs and complications. The ALL occurs primarily in children and young adults. The chronic leukemia, the CLL and CML, this is a high proportion of the mature cells. There's insidious onset. This one has milder signs, a better prognosis, but this one is more common in older adults. So again, the acute, immature, non-functional cells in the bone marrow and peripheral circulation, the onset is usually abrupt. ALL is the most common childhood cancer between the ages of 2 and 5, and it accounts for 80% of the childhood leukemia. The AML, it's more common in adults. It's associated with exposure to radiation, certain chemicals like benzene, viruses, or after a course of chemotherapy involving the alkylating agents. With acute leukemia, frequent or uncontrolled infections. I opened up with this. I said, even though there's more white blood cells, because they're non-functional, these people have more infections. Okay, can also be severe hemorrhaging in the brain and the GI tract due to thrombocytopenia, meaning decreased white blood cells. Signs of anemia, severe and steady bone pain. This is pretty significant. So you have this increased production of these non-functioning cells, and they can stagnate inside of the bones, creating bone pain. There could be weight loss, fatigue, fever, enlarged lymph nodes. Spleen and liver can also become enlarged. A headache, visual disturbances, drowsing, and vomiting with acute leukemia. This one, really important to know that there's uncontrolled infections due to non-functional white blood cells. Really important there with the acute leukemia. Remember, with chronic leukemia, this one is more insidious in terms of the onset. There are milder symptoms, and this one may be diagnosed on a routine blood check. Early signs, fatigue, weakness, and also frequent infections. For diagnostic purposes, peripheral blood smears will show immature leukocytes and altered number of white blood cells. The number of red blood cells and platelets decreased, and they need to do a bone marrow biopsy for confirmation for this. And the treatment is chemo, ALL in young children. They respond very well. And in terms of biological therapy, they use interferon. They try and use that to stimulate the immune system.